So over to you, Krishna.
Right. Thank you, Hitesh. So this is basically a small, like for the next 25-30 minutes, we'll be talking about coronal plane deformities of the lower limb. That is the principles involved in deformity analysis as well as correction of the deformities. So the next 20-25 minutes, we'll be talking on this particular topic. The objective of this webinar or this lecture is to give you an idea about how to analyze the coronal plane deformities of the lower limb, and our specific focus would be on tibial deformities because it's the simplest of the lot, and once you are into that particular workflow, it's going to be the same whether you are dealing with femur or whether you are dealing with an upper limb bone. So we'll start off with tibial deformities, and this particular lecture will be focusing on tibial deformities. We will be touching around with the femur also, but mostly on tibial deformities. So once you are done with this, you will get an idea about how to plan a correction in case of a tibial deformity. And once this is done, the same principle applies to the sagittal as well as oblique plane deformities. Oblique plane deformities are a little bit complicated. You need an idea about the sagittal plane correction, and then you need to assess both together, that is the coronal as well as the sagittal plane together, and then you make a protocol for the oblique plane deformities. So why do we choose coronal plane deformity analysis to start with? The reason is the coronal plane deformities are comparatively very less forgiving compared to sagittal plane deformities, because if there is a coronal plane deformity of the lower limb, like if you have a varus in the femur or tibia, the entire assault is going to be happening at your knee joint. The knee already has a tendency to degenerate, and when there is an exaggeration of the, like everybody has a little bit of varus, a couple of degrees of varus. So if there is an exaggeration of the varus, or if there is a reversal of the curve, like if there is a valgus deformity, the chances of your knee getting degenerated is much higher. That is why coronal plane deformity analysis and correction is given much more importance compared to other deformities. So these are the two common deformities that you see when you are dealing with coronal plane, that is the varus and the valgus deformity. So we'll be focusing on varus and valgus deformities of the lower limb. So in that image, you can see three different pictures. Externally, if you see, everything is looking almost the same. But when you look inside, there are bones as well as the joints. This is just a simulation of that. The first image shows different alignment. The second is again different. The third is also different. But externally, once the muscle cover is there, everything appears to be similar. The first one has a joint obliquity. The middle one is almost the normal alignment that you see. You see a straight joint line. And the third is a deformed bone and a deformed joint. So if you have a large magnitude of deformity, that can be externally made out. But if there are only minimal deformities, like especially when you are dealing with these juxta-articular deformities and all, the external deformity might appear to be much lesser. But when you take an X-ray and analyze the deformity, it's going to be much more. So that is the importance of deformity planning. And if you are planning to do deformities on a regular basis, and even if you are a trauma surgeon, this is one book that you should definitely read. That is Rod Paley's Principles of Deformity Correction. It has everything about deformities. Now, just a little bit of mathematics before we go into the real deformity correction part. If you want to draw a line, you have to either have 2 points, that is connect 2 points, or the second option is you have a line, you have an already existing line, you have a point on that line and an angle. So you can draw a second line at a fixed angle to the first line. So now we come to the deformity proper. There are axis lines. So deformity correction is basically a little bit of geometry. So you have two axes when you are speaking about a limb. That is, one is the mechanical axis, which is actually the line of weight bearing. It connects from the center to the center of the adjacent joints. And if you want to take the whole limb, it connects the most point of the center of the proximal most joint and the center of the distal most joint of that particular limb. And anatomical axis is the simplest thing, that is the mid-diaphyseal line of a particular bone. It's only regarding a particular bone. You can't draw an anatomical axis of the entire limb. It's only for a particular bone. So let's come to the two terminologies. One is like alignment, and the second is actually what you call the orientation. Now, these are two different terminologies which we would be using regularly once we start discussing about deformities. The alignment is actually the relationship between the hip, knee, and ankle to each other. Like they follow a particular relationship between each other in a normal limb. Orientation is something different, which is the relationship of the axis lines of individual bones to their adjacent joints. Like if you have a femur, if you have a mechanical axis of femur, that has got a particular relationship with the hip joint as well as the knee joint. Similarly, if you are talking in terms of tibia axis has got a relationship with the knee joint as well as with the ankle joint. So these two terms are important, and your ultimate aim of any deformity correction surgery is to restore the alignment and orientation of the limb to normal. So what is normal alignment of the limb in the coronal plane? The normal alignment of the limb means the collinearity of the hip, the knee, and the ankle. So if you are drawing a line from the center of the head of femur to center of the ankle, center of the head to center of the ankle joint, your knee joint should lie in that particular line. So collinearity of the hip, knee, and ankle, that is what you call a normal alignment of the lower limb in the coronal plane. So that's a clinical example. You have a pretty straight lower limb. The line drawn from the center of the head to the center of femur, head of femur to center of the ankle is passing through the center of the knee joint. When you're talking in terms of the joint orientation lines, you have three joints like hip joint, knee, and the ankle. So joint orientation line, the basic principle is that when a patient is weight bearing, your limb goes into a little bit of adduction when you're walking. And when you're adducting that, all the three joints, that is the hip, the knee, and the ankle joint orientation line should come parallel to the ground. It's only when it comes parallel to the ground, you say that the orientation is normal. So you have a hip joint orientation line, which is from the center of the head to the tip of the trochanter. At the knee, you have, in fact, two joint orientation lines. One is that of the distal femur, which is a line connecting the two most prominent points of the femoral condyles. Then you have a third line, which is the upper tibial joint line, which connects the upper surface of the tibia. And ankle, you have the joint line, which is running parallel to the joint and connects the medial most point of the lateral most point of the medial malleolus and the lateral end of the tibial plafond. So all these lines, when you weight bear, has to be parallel to the ground. So these are the hip joint orientation lines, the knee joint orientation lines, and the ankle joint orientation lines. Now, you need to have an understanding about the mechanical axis of the limb as well as the mechanical axis of a particular bone when you are planning a deformity. So each bones of the lower limb, that is the femur and the tibia, they have got a mechanical axis and they have got an anatomical axis. Now, what is anatomical axis? It's just the mid-diaphyseal line. In this lecture, we will be dealing mainly about the mechanical axis because compared to anatomical axis, mechanical axis is much more important. Because ultimately, your aim of any deformity correction surgery is to correct the mechanical axis to normal. So if you take the femur, it is the center of the head to the center of the condyles. That is the mechanical axis line of the femur. If you take the tibia, it is the mechanical axis goes from the center of the tibial, that is the midpoint of the tibial spine, to the center of the plafond. Now you have an anatomical axis also in the tibia, which is parallel to the mechanical axis. So when you are taking tibia, the anatomical as well as the mechanical axis are almost the same. Whereas in femur, your anatomical axis is different from mechanical axis, because all of you know that there is a 7 degrees of mechanical and anatomical axis deviation when you think in terms of femur. So that is the mechanical axis of tibia and femur. And when two lines meet, you get an angle. And by convention, you prefer to name the acute angle. So it is the acute angle that is always taken into consideration. And a bisector means, and when we proceed with this lecture, we'll be using this term bisector. And when we tell bisector, it means a line which is bisecting the obtuse angle. So two terms, one is the acute angle, which is usually used for nomenclature. And the second is the bisector line, which bisects the obtuse angle. The joint orientation lines of femur, that's the proximal and the distal joint orientation lines. And you can see that there is a relationship between the mechanical axis and the joint orientation lines. So you have four angles. When you're talking about the lower limb alignment, there are four angles. One is the proximal femoral angle. Then you have the distal femur angle, proximal tibial angle, and the distal tibial angle. So in fact, there are four angles: proximal femur, distal femur, proximal tibia, and the distal tibia. And all these angles are more or less equal to 90 degrees. That is one thing that you can remember. It's very easy to remember. There are slight variations, but it's almost equal to 90 degrees. So if you are talking about the proximal femoral angle, the lateral proximal femoral angle is 90 degrees. There can be a variation of 4 degrees plus or minus. Then you have the distal femoral angle. Again, it is the lateral distal femoral angle because it is the acute angle. It's 88 degrees. You have the proximal tibial angle, but here, instead of lateral, you are taking the medial proximal tibial angle. Why? Because the medial proximal tibial angle is acute. So medial proximal tibial angle, it's again 87 degrees plus or minus 4 degrees. Then you have the lateral distal tibial angle, which is 90 plus or minus 4 degrees. So all these angles are more or less close to 90 degrees. So your ultimate aim is to restore these angles and to get a collinear hip, knee, and angle. So once you understand these lines and the joint orientation angles, then rest of the things in deformity correction is much more easier. Joint line congruence, that is another thing that you should be careful of. Like in majority of cases of osteoarthritis, you see the cartilage loss, and when the patient walks with a varus, usually the tibial and the femoral angles are usually normal. But what you see is a opening up of the joint or a converging joint line. So if it's 3 degree medial convergence, it's normal, 0 to 3 degrees. If it's less than 3 degrees, it's fine. But if it goes more than 3 degrees, that means you have a lax joint. So where lies the significance of these lines and angles? Is this only for a deformity correction surgeon? No, the answer is a big no. Why? Because whenever you are reconstructing trauma, the ultimate aim of reconstructing any fracture is to restore these lines. I don't know how frequently we check this when we do a DHS, or say when we do a femoral nailing or a plate. We hardly ever think about this. But when it comes to arthroplasty, all the people are very much worried about restoring the angles, restoring the lines and all. But this is equally important even if you are a trauma reconstruction surgeon, because even in my case, only some 30 to 40% is the deformity correction surgeries. Rest is again the trauma surgeries. So in trauma surgery, you become a better trauma surgeon once you are well versed with these angles and lines. So what happens when there is a malalignment? So when there is a malalignment, ultimate result is a degenerated knee. So correction of alignment and correction of these orientation lines, the primary aim is to restore the alignment and to prevent the degeneration of the knee and its associated problems like ligamentous laxity, instability, etc. The consequences of malalignment: the knee is the most vulnerable joint in the lower limb because the articular cartilage has got only a very low healing potential. Normally, if you take a normally aligned lower limb, 70% of the weight passes through the medial compartment and 30% through the lateral compartment. Any change in these values, like there is an accelerated degeneration. Like if a patient or a person has 3 or 4 degrees of varus, what happens is 90% of the load passes through the medial joint line and it leads to a medial compartment degeneration. The reason for osteoarthritis is purely mechanical. So, and there is a resultant effect on the ligaments also. We'll come to malalignment and malorientation. Now, when there is a malalignment or when there is a malorientation of the joint lines, we get a deformity. There is loss of collinearity and abnormal orientation angles. So now we are coming to the deformity correction proper. Now, first thing that you want to find out is whether there is a deformity or not. And the second thing is, if there is a deformity, the next thing you want to find out is where actually is the deformity. Then only you can plan correction. Like initial days, we used to say that varus is usually corrected in the tibia and valgus in the femur. That particular thing is gone now. You have to assess properly. You have to find out which bone is deformed. And next is you go for correcting that particular deformity. So it can be an intraosseous deformity, or it can be an extraosseous deformity like ligaments, joints, and muscles. In this particular session, we'll be focusing mainly on the intraosseous deformities. The different types of deformity, what you see in the coronal plane can be an angulation, it can be a translation deformity, rotation deformity, a shortening, but most commonly what you get is a combination of these deformities. Isolated uniplanar deformities are comparatively rare, except where you see what you see in the usual osteoarthritis knee scenario, where you get only the varus. But there are most of the cases like congenital deformities and all are usually a combination of these four things. So it can be a pure angulation, it can be a translation deformity, it can be a rotational deformity, or it can be a shortening or absence of a segment of a limb. Like in a proximal femoral deficiency, you can have varying degrees of femoral deficiencies. I would be focusing mainly on the radiological analysis part, because clinical examination is important, but the most important aspect that you have to cover is the radiological analysis of a deformity. That helps in intraoperative checking, and also postoperatively, whether your correction is perfect or not, you can be clear with your radiographs. So this is the gold standard for deformity analysis, a full-length radiograph, right from the hip to the ankle, a single exposure. It should be a single exposure. The patient has to be positioned at a distance of 10 feet from the X-ray machine. The exposure factors should be set up for the hip joint, and the beam should be centered at the knee. The pelvis should be squared. So these are the basic things that you have to take care of when you are taking a full-length radiograph. And the most important thing is the patella should be facing dead forward. So a squared pelvis, patella at the center, the distance between the X-ray tube and the subject should be 10 feet, and the beam should be centered at the knee joint. Now, what does these full-length X-rays help us to do? They've helped us in finding out the location of the deformity, helps you to plot the mechanical axis, find out the magnitude of the deformity, and also once you are done with the correction, you can check whether your final alignment is perfect or not. And you can note that there is a white ball at the somewhere near the knee joint. That is the magnification marker that we use. It's a 30 mm steel ball that we use, which helps us to calibrate the X-ray when we are when we input these X-rays into the software. Nowadays, we use softwares for analysis. Earlier, we used to draw these lines on the X-rays using pencils. So mechanical axis deviation, that is the first step in deformity correction surgery, the mechanical axis deviation. So what is mechanical axis deviation? You find out how much the axis is deviated from the center of the knee joint. You connect the center of the head of femur to center of the ankle and measure the distance between the center of the knee joint and the actual axis line proper. Normal is 8 to 15 mm deviation is considered to be normal. Anything more than that is something which we give the terminology as mechanical axis deviation. So if it's a medial deviation, you call it a medial mechanical axis deviation. The first image is a varus of the knee joint, varus tibia, where the axis is deviated medially. And the second one is a valgus femur, where the mechanical axis deviation is towards the lateral side. So mechanical axis, if it's passing through the center, it's considered to be normal. Any amount of deviation to medial or lateral helps to define the deformity, whether it's a varus or a valgus deformity. So mechanical axis deviation is specific to define a deformity. Now, once you define the mechanical axis, find out the mechanical axis deviation, the next step in deformity correction surgery is to find out which bone is deformed. Like if you want to find out whether the femur is the problematic bone or the tibia is causing the issue. So for that, what you do is you draw the mechanical axis of individual bones. You draw the mechanical axis of femur, the distal joint orientation line and the lateral distal femoral angle, which is 88 degrees. It's close to 90, so it's normal. You draw the tibial mechanical axis, the proximal tibial joint orientation line, and look at the medial proximal tibial angle. It's 64 degrees, so it's well away from the normal 90 degrees. So there is around 26 degrees of deformity in the tibia. So the conclusion is that the patient is having a tibial deformity. So this is how you go in a step-by-step manner. First of all, you draw the mechanical axis, find out whether there is a mechanical deviation or not, axis deviation or not. Then you go to the axis of femur, find out the LDFA, that is the lateral distal femoral angle. This is normal in this case. You go to the tibia, find out the proximal tibial angle, and this is abnormal. So it's a tibial deformity. Similarly, a valgus femur, you draw the axis lines. You found that the mechanical axis is deviated towards the lateral side. Femoral mechanical axis, femoral joint orientation line, it's 75 degrees. So again, it is abnormal. Now we'll go to the tibia and find out whether there is a tibial deformity or not. So that's the mechanical axis of tibia, joint orientation line of the tibia, and it's 91 degrees, more or less normal. It can be 87 plus or minus 4. So this is an example of a femoral valgus. See, when a single bone is deformed, it's fine, but sometimes what you get is a little bit of, I'll be coming to that later. You will get some deformity in the tibia. Either there will be another deformity in the tibia, which will be either compensating for that, or it might be a deformity in the opposite direction. Joint line congruence, it's fine. Here the joint line is fine. It's less than 3 degrees convergence. Now, once you are done with finding out the source of the deformity, whether the tibia or femur is deformed, you come to the next important aspects. That is the apex of the deformity. Where exactly is the deformity located? Which part of the bone is deformed? And the second is hinge, that is angle, that is the axis around which you do the correction. So the apex is otherwise called cora when you discuss about deformities. It's the cora means center of rotation of angulation, and hinge is otherwise called ACA, that is the angulation correction axis. So the cora is along the transverse bisector line of the meeting point of the proximal and distal axis. We'll discuss that in detail. The first image is a normal bone. You're drawing the axis. Consider that this is the tibia. Here your mechanical and anatomical axis are same. Joint orientation angles, that's fine. Now you have a second image where the deformity is actually in the middle of the diaphysis. So that is the axis of the proximal fragment. So how exactly do you find out the location of the deformity? So if a bone is deformed, you draw the axis of the proximal fragment and you draw the axis of the distal fragment. The meeting point of these two axis lines is going to be your apex of the deformity. So that is the axis of your proximal fragment. You go forward, draw the axis of the distal fragment, and you have a meeting point which is actually called the cora. Now, what if one of the fragments is very small? Like if you have a very proximal tibial deformity, how can you will not be able to draw an axis like this when the deformity is very close to the joint. So what is the other way of drawing the proximal axis? Now, when we discussed about lines, we told that the second method of drawing a line is to have one line, a point on that line, and a specified angle. And you know that these angles are close to 90 degrees. So you draw a line at 90 degrees to the joint orientation angle. So that is your proximal mechanical axis. The second line is your mid-diaphyseal line. That is the distal axis. So the point where these two meet is called the cora, or actually the apex of the deformity. Now we discussed about bisectors earlier. Now what is the significance of bisector? This is the obtuse angle that you see here, and you get a line which bisects or which divides the obtuse angle into two. So that is called the transverse bisector line. And your cora can be anywhere along this transverse bisector line. You can correct the deformity by placing your hinge anywhere along this line. It need not be exactly at the center. You can place your hinge here, you can place your hinge here, you can place at the convex end, you can place at the concave end. the resultant deformity correction will be a little bit different, but your axis lines will be aligned. So what is the ultimate aim of any deformity correction surgery? Like if you are going to correct this particular deformity, your ultimate aim is to align the green line to this purple line. That is the ultimate aim of any deformity correction surgery. So you can correct that by placing your hinge anywhere along this transverse bisector line. So where do you place your hinge? It's ideally placed at the level of the cora, that is somewhere along this transverse bisector line. If you have a hinge at the convex border, what you get is an opening wedge correction. If it's at the concave border, it's going to be a closed wedge correction. And if it is at the center, it's going to be a neutral wedge. We'll come to that in the next slide. Now, what is an osteotomy? An osteotomy is basically you are dividing the bone, and the aim of this osteotomy is to correct the deformity, and it's your ultimate aim would be aligning these two axes. That is the green line to the purple line. So the different types of osteotomies are opening wedge, closing wedge osteotomy, neutral wedge, and then angulation translation osteotomy, and dome osteotomies. Dome is a little bit of technically demanding, so we won't be discussing dome osteotomy right now. So what is opening wedge? That's the two axis lines. You have a green line and a purple line, violet line actually. You are keeping the transverse bisector line is there. You are keeping your hinge on the convex border of the bone, and you correct it. Now you can see that these two lines are aligned and you have an opening wedge here. So that is the opening wedge osteotomy. The next one is the closing wedge osteotomy, where you keep your hinge at the concave border and you do a closing wedge osteotomy there. So that is the amount of bone that you have to remove, the wedge of the bone that you are going to remove when you are doing a closing wedge osteotomy. The third is a neutral wedge, where you remove a wedge of bone from here and place that wedge outside. A neutral wedge is very, very rarely done. Usually what you do is either an opening wedge or a closing wedge osteotomy. There are certain rules that has to be followed when you are doing an osteotomy. The osteotomy rule 1 is you have a transverse bisector line here. A cora is there at the transverse bisector line. You place your hinge at the level of the cora. You correct it. What you're getting is a pure angular correction and the axis is well aligned. So osteotomy rule 1 says you need a cora, you place the hinge at the cora and do a closing wedge or opening wedge, whatever you want, and the axis is aligned. It's a pure angular correction. That's an example. It's a varus tibia. You have the proximal axis and the distal axis. There is a transverse bisector line. That's a hinge that I've placed at the convex border, and that's an opening wedge osteotomy. That's a rule 1 closing wedge osteotomy, where you have a proximal axis and a distal axis. It's a small child, so I prefer to do a closing wedge osteotomy here. Kept the hinge at the concave border, removed a wedge of bone and corrected it and fixed with wires. It's a small child, and that's the X-ray and the clinical picture after correction. It's an epiphyseal dysplasia. So look at the left side. This is how you plan for your procedure. You have a wedge removed, and this wedge is actually kept as a reference while you are doing the osteotomy on table. Osteotomy rule 2 is hinge. Again, it's kept at the cora, but you are doing an osteotomy somewhere away from the actual level of deformity. So what is the situation in which you do this? Like in a case of proximal tibial deformity, suppose the apex of the deformity is proximal to the tibial tuberosity, you will not be able to do the correction at that particular level. Your osteotomy has to be a little bit away from the apex of the deformity. So in that case, if you place the hinge at the level of the cora, but you do an osteotomy distal to that, or say proximal to that level of deformity, this is one situation which commonly arises when you are dealing with malunions. Malunited fractures many a times will have sclerosis at the apex of the deformity. So it won't be a good idea to do an osteotomy at a sclerotic area. So what you do is you do an osteotomy a little bit proximal or a little bit distal to that apex of the deformity. So you keep a hinge at the level of the cora, but you do an osteotomy distal to that and rotate. Here, along with angular correction, what you get is a little bit of translation also, but you can see that the axis is perfectly aligned. If you keep a hinge here and try to rotate it, you will get these sort of perfect corrections. And this bump in due course of time will get remodeled. All right. So that is osteotomy rule number 2. You have a cora, the hinge is at the cora, but osteotomy is at a different level. Axis lines are aligned. So that's a varus tibia. The deformity is very proximal. So the cora is somewhere very close to the joint, just below the tibial spines. So we did an osteotomy distal to the tuberosity, and using a juxta-articular hinge, here actually we use the 6-axis correction system, corrected the deformity. So that is the most important application of osteotomy rule number 2. This is the most commonly used osteotomy rule. Now third is osteotomy rule 3, where you have a cora, but you keep a hinge away from the cora and do an osteotomy away from the cora. Here what you get is you get an angular correction, but what happens is the axis is translated. The axis is not aligned. So osteotomy rule 3 is something which you will not use. 1 and 2 are most commonly used, and the rule number 3 is just for your knowledge. You should not do an osteotomy. You should not do a correction like this. The hinge has to be kept at the level of the cora, but your osteotomy can be proximal or distal to the apex of the deformity. We'll go to a clinical scenario. This will give you a better idea of how to go about. This is just to show the workflow of how to assess a deformity. So, 13-year-old girl with a progressive varus of the left knee started at the age of 11. She's a high jumper. So she had difficulty in walking and mild pain. That is a clinical picture and the X-ray. And you can see that there is an obvious tibial varus here. Now we'll go to the deformity proper. I'm just showing a small video. Today, nowadays, we do this with softwares. There are a lot of softwares available. I personally work with Bone Ninja. That is, you're magnifying the X-ray there. And this is the calibration tool. You can superimpose this tool onto your magnification marker and enter the value in the window provided. So once that is done, your calibration is proper. You will get a perfect measurement when you are doing the analysis. The next step is to draw the mechanical axis of the limb. And you can see that there is a medial mechanical axis deviation. The axis is passing outside the bone. So there is a medial mechanical axis deviation and a varus deformity of the limb. Now the next thing is you have to find out which bone is actually deformed. So that is the mechanical axis of femur. You can play around with these lines. So it's from the center of head of femur to the center of the to the apex of the notch, femoral notch. That's the mechanical axis of the tibia that we are drawing. Mechanical and anatomical axis is same in case of tibia. And you see that there is about 13-14 degrees of varus in the limb. All right, so now there is a varus deformity and you have 13 degrees of varus. The next thing that you do is you find out which bone is deformed. So I'll go to the tibia first. So you draw the proximal tibial joint orientation line. It's a juxta-articular deformity, so I can't rely on the axis here. I have to draw the joint orientation line and the proximal axis at a specified angle, that is 87 degrees medial side, MPTA of 87 degrees. Distally, I can go along with the mid-diaphyseal line. And now here I see that there is around 23 degrees of deformity. Our net deformity was 13 degrees, but here I'm getting 23 degrees of the varus of the tibia. So what is the issue here? The issue here is there is a deformity in the distal femur also, which is valgus deformity. So I am having 23 degrees of varus at the proximal tibia and 10 degrees of valgus at the distal femur. So the net deformity is only 13 degrees. So that is the importance of deformity analysis. This is something which you are likely to miss when you are dealing with spot fillings. If you have only an X-ray of the knee joint, there is all the possibility that you are going to miss the distal femoral deformity. So that is the importance of full-length X-rays and proper deformity analysis. The next thing we do is we plan the osteotomy. And this is how the osteotomy is planned. I'm planning to do distal to the tuberosity away from the apex. So I'm going to use osteotomy rule number 2. And that is the hinge that is placed. See, the osteotomy is lower down, but my hinge is exactly at the apex of the deformity. Now I rotate, and this is the correction that I'm planning to do. So everything is in your hand before you go into the operation theater. So only the 30% of the work is left in the operation theater, rest is done outside. So once you have this picture, once you have a printout of this and you're pasting it on your X-ray lobby, things become much more easier. So just to summarize, that's a mechanical axis deviation, medial mechanical axis deviation. There is an abnormal MPTA as well as an LDFA. So there is a femoral deformity as well as a tibial deformity. So that is the cora, proximal tibial cora and the distal femoral cora. Both are very close to the joint lines. So here, this is how I plan the correction. I'm planning to correct a tibia by doing an opening wedge. It's distal to the tuberosity. So I'm going to use a ring fixator here. That's my personal choice. You can use any implant which you are comfortable with. You can do a closing wedge also. Distal femur, I'm trying to do an opening wedge, but here, since the deformity is at the level of the epiphyseal plate, I'll be doing a guided growth here. Epiphyse is still open, she's only 13 years. And that's the final correction. I used a ring fixator for the distal tibia, proximal tibia. I used a 6-axis correction system, gained a little bit of length and corrected the deformity. For the distal femur, I used a 8-plate. The femur is a little bit under corrected, but that is fine. Like the axis is perfectly at the center. A little bit of joint obliquity is there. So now the question arises, once you are done with this, the question arises whether you want to go for an acute or a gradual correction. The gradual correction is, if the advantages of doing a gradual correction is you can correct the exact degree of deformity, and there is always a perfection of correction because you have the option of fine tuning in the postoperative period. Once the correction is done, you can go to the X-ray room, take a full length weight bearing X-ray and find out whether the axis is aligned and whether your joint orientation angles are restored to normal. And any limb length discrepancy is there, you can correct it with a fixator. Acute corrections are, personally, I perform it very less frequently. In very small children, we prefer a closing wedge and an acute correction. And LLD cannot be corrected. That is, limb length discrepancy cannot be corrected when you are going for an acute method. The choice of hardware, it's a surgeon's preference. None of us, like there are many of us doing Ilizero ring fixator. Ilizero is our personal choice, but we never recommend Ilizero people to do Ilizero for every case. Ilizero definitely has its own place in deformity correction surgery, but if you are not comfortable with Ilizero, you can use plates or nails, whatever you want, whatever you are comfortable with, but do it in the proper way. Like if you are doing a plate or if you are doing a nail, if the deformity warrants some amount of translation, your hardware choice has to be depending upon that. So a lot of things depend upon the patient as well as the deformity parameters. The type of osteotomy, whether you are doing an opening wedge or a closing wedge, and the level of the osteotomy also. Certain deformities, like if you are dealing with very deformities that are very close to the joint, sometimes you find it difficult to fix with a plate or a nail. In that circumstance, you will have to use a ring fixator. That you would be left with only one choice. So a lot of things depend upon the deformity parameters as well as the patient parameters. But ultimately, do whatever is comfortable in your hands. Thank you very much. So this is in a nutshell how to deal with coronal plane deformity, especially that of the tibia. And if you have any queries, you can mail me at any time you want. Thank you.
Krishna, that was an excellent presentation.
Thank you.
Thank you very much for the presentation. I think the concepts have been very, very clear. And a couple of queries.
Yeah.
One is, can you explain what is the malalignment test?
Should I go back to that slide? That would be, I think.
No, someone just asked me. Just a small brief.
Right. So malalignment test is to find out whether there is a deformity or not. So that is the first step in deformity correction. You take a full length X-ray. You draw the axis of the limb. That is, mark a point on the center of the head of femur and mark a point on the center of the ankle joint. Then you connect these 2 points, and normally if your alignment is normal, it should pass through the center of the knee. So if this is passing away from the knee, that is in varus, it passes medial to the joint line. And if it is a valgus deformity, it passes away from the that is lateral to the knee joint. So that is something called the mechanical axis deviation. Now, once you are done with mechanical axis deviation, you have to find out which bone is deformed. That is, whether it is the femur or is it the tibia that is deformed. So for that, you draw the joint orientation lines. You mark out the axis of femur and axis of tibia. So axis of femur is from the center of the head to the center of the knee. You find out the joint orientation angles, whether that is normal or not. The most commonly used things are the lateral distal femoral angle and the medial proximal tibial. So if there is an abnormality in any of these angles, that means that particular bone is deformed. Like if you have an abnormality of the lateral distal femoral angle, that is a femoral deformity basically. And if it is a deviation, if it is a variation in the MPTA, that is the medial proximal tibial angle, it's a tibial deformity. So this is how you do the malalignment test. The next part is to find out the orientation, that is the mal orientation test. Now, once you find out that there is a malalignment, you plot the proximal and distal axis of that particular bone, and you check whether these axes are at correct angles to these joint orientation lines. And if these axes are at correct orientation to these joint lines, then your ultimate aim is going to be your correction of the axis, alignment of the axis. So that is malalignment test. And the second part of, and after you do a malalignment test, you do the malorientation test.
Okay, so that was pretty clear. Thank you very much. And the other question was, see, suppose you have multi-apical deformities, right? When there are more than 2 apices.
Yeah.
And then how do you go about it? Because sometimes the cora lies totally outside the bone.
Now you have 2 options there. Like when you're dealing with a multi-apical deformity, something which you get in these many of these congenital anomalies like osteogenesis imperfecta and all, you get these uniform bowing of the tibia or femur, where you have got multiple apices. So in that situation, what you do is you plan properly. That is, you plan according to your normal thing itself. Like you draw a proximal axis line and a distal axis line. It will usually intersect outside the bone. So that is something you call the resolution cora. So either what you can do is you perform an osteotomy at the level of the cora and correct it. But what happens is ultimately, like you have a banana, like you think about it, you have a banana, you cut the banana in the center and straighten it out. You get 2 curvatures, but ultimately it's going to be a straight line through the center. So that is one way of doing the correction. The second way of doing a correction is like the classical seek kebab osteotomy, where you do multiple osteotomies at different levels and make it straight. So what you do is you pass suppose you are correcting with a nail, you pass a reamer, the point at which the reamer touches the bone, you do an osteotomy there, straighten it out, go through the second fragment, again cut it, again go through the third fragment. So this is similarly you do on an X-ray also. You draw the proximal line, it meets at one point. So proximal line is easier. You can draw it using your joint orientation line. Then what you do is you draw the distal one also and draw a third line through the center of the bone, which is an arbitrary line which passes through the center but connects both the proximal and distal axis. The easiest way to understand is the seek kebab osteotomy. Pass a reamer, that's the proximal axis, cut it, correct that deformity, pass it through the second fragment, again that becomes the axis. So these 2 axes are now aligned. Now you go to the third fragment. So that is what you do when you are dealing with a multi-apical deformity.
Okay, so that's pretty clear. The other thing was with someone got confused with Fujisawa's point and the midpoint of the knee. So explain to them what is the
Fujisawa point is something which you often hear when you are dealing with high tibial osteotomies. Fujisawa's point is actually lateral to the lateral tibial spine. So that is something which is when you are doing a high tibial osteotomy, what your ultimate aim is your axis passes through the Fujisawa's point. But what we usually do is nowadays we are not bothered about Fujisawa's point. We aim to get a HKA axis, that is the hip knee ankle axis at 183 to 186 degrees. That is effectively 3 to 6 degrees of valgus. That is ultimately what you need. Fujisawa's point is lateral to the lateral tibial spine. That is something which many textbooks and many literature tells about Fujisawa, your ultimate aim of getting the axis aligned to the Fujisawa spine. But if you are treating osteoarthritis, the best thing is always aim at a hip knee ankle axis of 183 to 186 degrees. The center of the knee is different. Like if you are talking about the normal axis, it usually passes between the two tibial spines. So that is the difference between Fujisawa's point and the center of the knee.
That's clear. So a normal axis goes between the spine.
Yeah.
I mean the tibial spines, and the Fujisawa's point is immediately lateral to the lateral tibial spine.
Lateral tibial spine.
Okay, so that is, some people get confused with that. Fujisawa's point comes in the axis.
Yeah, Fujisawa's point is what you aim to get when you are dealing with osteoarthritis.
Osteotomy, right?
Yeah.
Okay. So I think there are no more questions, Krishna. So that was a brilliant presentation. Thank you very much for sparing your time with us. We look forward for more lectures from your side because of the crystal clear nature of your presentation. Thank you very much. Okay, I'll end the meeting.